Good morning, girls. This will be our second case study that we'll do via recording, and hopefully it helps to answer your questions. And please text me or email me if you have questions after this, and or if I say something wrong like I did in the last one, something that's blatantly incorrect. I've spent a few minutes doing an SBAR on this patient, and we're going to go over all of his information, and it's really relevant to what you guys are doing in lab and trying to choose settings for patients and thinking through the disease process prior to initiating therapy. So we're going to just do a case study of a patient that we have here, and we'll have some calculations and things that you guys can do on your own afterwards, and just kind of go through his disease processes and his clinical presentation and what we need to think immediately when we see someone like this come in. So today I wore my Be Kind t-shirt to remind you guys to be kind, but mostly to remind myself to be kind, because I'm prepared for being a respiratory therapist during a pandemic, because I was trained for that and I went to school for that, and I appreciate everybody's posts and everything everybody's saying about RTs, because it's good press, and it's really nice to be appreciated for all the hard work that all of my students are doing, all my coworkers, and be really proud of your RT, your fellow RT, your classmates, your clinical instructors, your just any RTs. Just be proud of them during this time, because it isn't easy. But I was trained to be an RT, and that part's been a little bit easier than being a homeschool mom of three, 2 teenage and 1 preteen boy. That part, I'll get you. So I'm wearing a shirt that says Be Kind, so I can remember to be kind. When I look in the mirror, I gotta be kind. So that's my goal for today. So I'm gonna wear the shirt to remind us, and let's get started on an SBAR. Okay, so our situation for this patient is a 67-year-old male. He was admitted for frequent falls, a COPD exacerbation, and when EMS found him, he was hypoxic in the 60s. So immediately we've got a light bulb going on here. Was he wearing his oxygen? Was he this hypoxic with or without oxygen? So that's kind of something we don't know, and it's not clear by looking in his history when they found him if he was or was not using his home oxygen. So he is on home oxygen at 4 liters, continuous, 6 with exertion. So we don't know if he was wearing that or not, but this was his presentation. He is a DNR DNI. So immediately when we have someone coming in that's having a COPD exacerbation, he's hypoxic, and if they did find him in the 60s, we kind of need to know his code status, because we need to know immediately if we're invasively or non-invasively going to help this patient out if he gets into trouble, for if he's having hypoxic or hypercapnic respiratory failure, and we just aren't sure quite yet. So there's our situation, comes in. He has a history of untreated sleep apnea, pulmonary hypertension, right-sided heart failure, severe COPD, and he's a smoker, current smoker, not interested in smoking cessation. So we kind of look at these things, and all of a sudden we're thinking, well, okay, these two things go hand in hand with this. So this is kind of a little bit of something that we would normally see. And we know that untreated sleep apnea is only going to add to our heart issues and our pulmonary issues. So we look at this, and we think, okay, we've immediately got to start thinking about what we're going to do to treat this patient, okay? Abnormal admission labs, his creatinine was low. We're not super low, but a little low. Chloride was low. CO2 was high, and this is on a chemistry, not on an ABG, but we'll see that in a second. It's a little alarming, okay? BNP was elevated, so you guys know what the BNP is. That's a peptide specific to the left ventricle, so that's up a little bit, well, a fair amount actually. And so we know that there might be a little bit of extra pressure being put on that left ventricle, and we gotta look in here and kind of wonder why. We look up here and see the hypoxemia, the COPD, and we think untreated sleep apnea. We think there's a possibility some of that could be contributing to this pressure on that left ventricle. His white blood cell count was only 2, so we're not thinking he probably has a pneumonia here, but he is a COPD patient, and so we needed to, we needed to check and see he was afebrile. Platelets were low. Platelets were pretty low, so that's a little bit concerning. And I believe his red cell count was just a touch low, but nothing real alarming that I wrote it down, okay? Here's his admission ABG. Hope you guys can see this. I hope I'm not shaking too bad. I've only had a pot of coffee today. Okay, so this is on 50% FiO2. So your FiO2 is 50%, and this is just via a mask. So it's, I believe, he was brought in on a Venturi mask. You don't see those a lot anymore, but that's what they were utilizing for him. So pH 735. Okay. PaCO2, and this is not written incorrectly, is 92. His PaO2 was 93. His bicarb was 52. His base excess was 19.4. So immediately, what are we thinking here? So is this in the normal range? Yes, it's on the bottom side of normal, but it is in the normal range. Is this in normal range? No. Is this in normal range? This is actually too high for this patient, so we need to turn this down, but I suspect when they found him in the 60s at home, they just slapped him on 50% and were a little hesitant to take it off at that point. So PaO2 is high. His bicarb is 52. So let's talk a little bit about that. I gotta figure out where I put my marker. There it is. Okay. Out of this, and okay, so this is normal, but it's on the low normal. Okay, so that's meaning he could be acidotic. Okay, forgive my spelling, you guys know how that goes. Okay, this is very high. And why would this be high? You guys know this. This is high because this is high. Okay, this is very high, and this is very high. So this is acidotic, and this is very basic. So what's going on here is that this patient is chronically hypoventilating, or has he has a chronic issue with hypercarbic respiratory failure. Okay, his bicarb, so much so that his bicarb is double what it should be, over double what it should be. Okay, so are we alarmed at this ABG, and does this make us think immediately we need to do something for this patient? Well, which one of these values does your body fight to maintain? Does it fight to maintain your PaCO2? Does it fight to maintain your bicarb? No. Your body is going to do whatever it can to normalize your pH. So this patient comes in, even though we know he's having some sort of a COPD exacerbation, he's really short of breath and he's hypoxic when they found him. We also can see here that this is definitely not an acute thing, but it might be a little bit acute on chronic. So his pH is within normal limits. So that part we're not going to get super alarmed about. What we are alarmed about is that that is normal for him. This PaCO2 is pretty normal for him. Now, do we want to try and normalize his CO2? When we talked about this, do we want to start ventilating him aggressively and blow off some of this CO2? And the answer is no, and you guys know why, right? We don't want to blow off all that CO2 because then he'll dump his bicarb. Your CO2 goes away pretty quickly. Once you get rid of your bicarb, it takes longer to build up. So we do not want to get too crazy because his pH is actually within normal limits. So let's break down the problem list and kind of see what we need to start thinking about as respiratory therapists. So the thing that we talked about that we always think about when our patients come in is, does this patient have an oxygenation problem? And how do you tell? Does this patient have a ventilation problem? How do you tell? So luckily we have a blood gas here. Does our patient have an oxygenation problem? Well, he's on 50% and his PaO2 is 93. So this is higher than it should be, but so is his FiO2. So we know that out in the field, he definitely had an oxygenation problem. We don't know if he was on 4 liters at home. We don't know what his FiO2 was when they found this saturation. We know that he probably has an oxygenation problem chronically because he's on home oxygen at 4 liters. And is he having an acute oxygenation problem? Probably. If it's taking 50% oxygen to get his PO2 to 93, it should be much higher. So he's got a little bit of an oxygenation problem. So that's kind of how we tell what's our FiO2 and what's our PaO2, right? So we want to think about that, our P to F ratio, okay? Does this patient have a ventilation problem? How do we tell? You guys know how to tell if they have a ventilation problem, because what is our telltale from that? That's going to be our PaCO2. Does he have a ventilation problem? Yes, he does. This should not be 92. But is it an acute problem? It's probably acute and chronic. So chronically, this patient has a ventilation problem. So what are we going to do for this patient who comes in with this severe COPD? But this is, both of these things are probably a chronic oxygenation problem and a chronic ventilation problem. We can kind of tell by the values we got from this ABG. And so then we kind of come over here, okay? So we think about our COPD, and you guys know all this. So here, the 3 issues we have with COPD are bronchospasm, secretions, and inflammation, okay? We talk about pharmacology and therapy for each one of these things, if there's something we can do as RTs to help. So we start thinking about bronchospasm. So the first thing, generally, these are the 3 main things that, 3 main symptoms that patients have with COPD. So they have bronchospasm, secretions, and inflammation. And you guys know all about this because we talk about it almost every day. Okay, so bronchospasm, we want to talk about pharmacology that we can use for these patients, SABA, SAMAs, LABA, LAMAs. So some kind of a bronchodilator, okay? So our pharmacology for our bronchospasm is bronchodilation therapy, okay? So we want to make sure our patient's on optimal bronchodilation therapy, and we start thinking about what this patient's on at home, and always when our patients come in, we like to think about what went wrong with our home regimen that brought them in here, so that when we discharge them, we can think about how to prevent that maybe from happening again. Sometimes we can, sometimes we can't. So we want to make sure we have optimal pharmacology for the bronchospasm. So our bronchodilators, we have SABAs, SAMAs, LABAs, LAMAs, and you guys know all about those. So your short-acting beta agonists, your short-acting muscarinics, your long-acting beta agonists, and your long-acting muscarinics. So are we doing what we can for this part for this patient? Therapy, I put pursed lip breathing down here. You kind of think about how those little airways at the bottom close off. And if you can get your patient to start pursed lip breathing before they get, it just helps to splint open those little airways down at the bottom and release some of that trapped air. So that might be about the only real therapy we have. Primarily we target the bronchospasm or the bronchoconstriction. That would have been a much better word there. Instead of bronchospasm, it should be, hold tight, bronchoconstriction. Yeah, that's a better word there. So bronchospasm, scratch that, and let's think more about that along the lines of bronchoconstriction. Okay, our second issue here is secretions. We know our COPD patients have secretions, okay? So pharmacology for secretion, so we're thinking of pharmacology and therapy. So pharmacology for that, really about the only thing we have for that is guaifenesin or Mucinex, something to thin those secretions. And humidity is a big one. If you're going to put a patient on high flow oxygen, you got to be considering humidifying that little bit of that oxygen that you're giving them, because like we talked about last week, oxygen's a very drying gas. So there is also humidity that we could do here. So pharmacology, guaifenesin, secretion clearance therapy. All of a sudden we're thinking like, what can we do for this patient for secretion clearance therapy? So let's just stuff humidity right in between here, because that's a good something for us to think about. So these are food for thought, right? Okay. So secretion clearance therapies, Aerobica CPT, any other secretion clearance therapies you guys might think of. So we kind of need to do our evaluation of this patient, our assessment, our pulmonary assessment, to see how serious we need to get about these, okay? So, and for the inflammation part, not much we can do as far as therapies, but we do need to make sure that they have adequate coverage in the pharmacology area. So if you have someone that's coming in with a severe COPD exacerbation, a lot of times they'll give them IV steroids in the emergency room, or once they get them to the floors or get them here. A maintenance, a lot of times they're on an inhaled corticosteroid. We know all about which ones those are and what those do. Sometimes, and this patient actually is on prednisone, and he's on 20 milligrams a day, and that's his outpatient regimen. So they're probably, he felt like the mometasone made him nauseous, so they took him off his ICS and they put him on PO prednisone daily. And then he did get some IV Solu-Medrol upon presentation into the emergency room. A lot of times they do this to target that inflammatory portion of the COPD. So those are things where we know with our patient coming in with the diagnosis of COPD that we're going to be contending with. And you guys know all about that, okay? So the other thing we have to think about here are, how severe is this patient's lung disease? So kind of about the only thing we can do other than looking at our patient to know how their lungs function at baseline are the pulmonary function tests. So I looked up this patient's PFTs for us, and we know the PFTs measure airflow, volumes, and diffusion, okay? So we do a pre-bronchodilator set of spirometry, volumes, and diffusion, and then we do a post-bronchodilator. And mostly this just affects the spirometry, and that's what we're looking for, is a positive bronchodilator response. So you look up here and you see about this bronchoconstriction, okay? So what part of the pulmonary function tests are going to be telltale of that level of that bronchoconstriction that this patient has? So we're going to check out his airflow. So typically for COPD patients, our airflow is going to be decreased. You guys know this, we've gone over this before. So this patient's FEV1 was 38% of predicted. Okay, he's 67 years old, and his FEV1 is 38% of what it should be. So forced expiratory volume in 1 second, 38% what it should be, okay? Post-bronchodilator, it did increase to 50% of predicted. So this is this is great news for this patient and for us, because the pharmacology we're giving for the bronchoconstriction really is working. So we do need to be mindful of the fact that he does have a positive bronchodilator response. Some COPD patients do, and some COPD patients don't, okay? His FEF 2575. So if you guys remember, the FEF 2575 is the small airways. So the little airways, his were 13% of predicted for what they should have been for him. And after his bronchodilator, he went up to 17% of predicted for that. So what do you make of this patient's airflow? You think about him coming in, SATs in the 60s, pretty good work of breathing, tachypneic, tachycardic, those kind of things. And you think about this airflow. So those are his airflows. So at baseline, And this is not even when he's having a COPD exacerbation. Okay, this is baseline spirometry, so normal day for him, not sick day. Okay, so his lungs are functioning. His FEV1, 38% are predicted, up to 50 post bronchodilator. Those small airways, 13% and 17%. So his airflow is really, really low. Okay, so if we have really low airflow, we think we've got a lot of bronchoconstriction. Okay, and then what's that going to do to our volume? So typically for a patient with COPD that has really low airflows, like this patient does, a lot of times we're going to have an increase in volume, right? We're going to have that air trapping that's going to increase those volumes. So I looked on the same set of PFTs, and these are baseline lung function tests. His residual volume was 307% of predicted. So he has 307% more of a residual volume than he should. His total lung capacity, 147% of predicted, and his residual volume to total lung capacity, this is a good indicator here, is 203% of predicted. So pretty characteristic for a COPD patient. Okay, we've got really decreased airflows, we have extremely high volumes, and his diffusion to corrected alveolar volume was 55% of predicted. So usually, and this is pretty stereotypical, like I said, typically your airflow will be low, your volumes will be high, and your diffusion will be low. And he pretty much fits the mold for that. This is pretty alarming, and this one's pretty alarming. Well, they're all alarming, but these are big ones where you see the severity of this patient's lung disease. Okay, it's good that he has this positive bronchodilator test, because we're going to be pretty diligent with our short-acting beta agonists and muscarinics, or combination medications, long-acting, that kind of stuff. So we do want to see what his outpatient regimen is, so that we know what got us here and what got him here. Okay, so that being said, there's kind of a little blurb on his COPD portion of this. Okay, this patient also has pulmonary hypertension and right-sided heart failure in his problem list. And if we think about these for just a minute, this one kind of causes this one, that kind of causes this one. So it's kind of a, excuse me, a little bit of a cause and effect thing. So we're going to go over here, excuse me, to our little box heart, and we're going to talk about that a little bit. So I looked up his echocardiogram that he had. So this is an echocardiogram on admission for him. So right ventricular hypertrophy and severe dilation. So we know that he's already got this right-sided heart failure, so we're expecting to see this right ventricle. So it's severely dilated, so they're actually calling it right ventricular hypertrophy. His left ventricle was preserved with an ejection fraction of 55%, so we're very happy to see that. That's good news. And then abnormal tricuspid valve, severe regurgitation. And I want you guys to think through why this is the case. And his right atrium has moderate dilation and moderate pulmonary hypertension. Okay, so let's go to our box heart and think through why this would happen. So when you have severe COPD, which we know this patient does, a lot of times you get something called chronic hypoxemia. Okay, so chronic hypoxemia leads to, oops, I'm erasing my other stuff while I'm writing with my, see, chronic hypoxemia leads to pulmonary hypertension. Pulmonary hypertension leads to right-sided heart failure, okay? So the blood comes from your body. So your unoxygenated blood goes into your right atrium. It goes through what? Your tricuspid valve into your right ventricle. So where does your right ventricle? So this is our hypertrophy here. So it pumps into what? Usually I write lungs, and today I actually wrote lungs. Okay, good for us. Okay, so the right ventricle pumps through the pulmonary arteries. So this is the only place in the body where that's backwards. Your pulmonary arteries and veins are backwards, and what this is carrying unoxygenated blood, where these are carrying oxygenated blood. So anyway, your right ventricle pumps to your lungs. When you have pulmonary hypertension in your lungs, this ventricle has to pump against a higher pressure. So when you're asking the muscle to pump against a higher pressure, it's going to start to fail. So he's got pretty moderate to severe pulmonary hypertension, and we know that can be caused from this chronic hypoxemia, and also a lot of times with that amount of air trapping he has, it can squish that vasculature too. So he's kind of got a couple of things going against him. He's got pulmonary hypertension, and then that vasculature is really squished because of his air trapping. So this right ventricle is having to push against a higher pressure. So over time, it's going to fail. Not only is the right ventricle starting to dilate and fail, also we're having tricuspid valve regurgitation into the right atrium. And so the right atrium's getting over full, and it's also starting to dilate a little bit. So on his echo on admission, he has right ventricular failure, he has tricuspid valve regurgitation, and a little bit, moderate dilation of his right atrium. And that all makes sense when you stop and think about it here in this little box heart, right? So we've got our pulmonary hypertension, we got our squished pulmonary vasculature, and then we've got our right ventricle trying to push against those things. So those couple of things are giving our heart a little bit of trouble, okay? He did have an elevated BNP, so not only is he having a little bit of issue with this right ventricle, even though he has a preserved ejection fraction over here, he is having some extra pressure on this left ventricle. We know that because his BNP is elevated, but it's not causing left ventricular failure, which we're happy for, because then not only would we have issues with this, we would have issues with it backing up this way, and then when it backs up into our lungs, we know the cascade of crap that happens. So we're fairly lucky that we have a preserved ejection fraction, and we're not showing too much of this left ventricular failure yet. All right, so that goes over, we went over his COPD, his pulmonary hypertension, and his right heart failure. Okay, I'm going to show you his chest film, and we'll talk about that a little bit. So what would you expect from this patient? Okay, I'm going to have to sign back in. I'm so sorry. Because I talked too long. I know that does not surprise anybody. Sorry about this. So what would you expect from a chest film from this patient after looking at the volumes and the airflow and his pulmonary function test? So with these COPD patients, a lot of times what you're going to see are long, tall lungs, and you might even be able to see a little bit of that dilation of the heart if it is indeed dilated enough that you can view it on chest film. So on a normal x-ray, normal inflation where your diaphragms come up it's around the 10th rib. So your diaphragms will hang out around the 10th rib. And I think that your left, the left diaphragm is usually, it's a little bit lower. So I think the left diaphragm is usually a little lower than the right, but they hang out with normal inflation of the lungs around the 10th rib. So if you have hypoinflation, those diaphragms are going to be up around your 8th rib. And if you have hyperinflation, so what do you think the hyperinflation is going to do to those diaphragms? And we've talked about this before. What you're going to see is you're going to see the air trapping, or that residual volume, and that trapped air in there, making those diaphragms a little bit flatter. So with hyperinflation, you're going to see flattened diaphragms, and your diaphragms are going to be down around the 12th rib. So hypoinflation, 8, normal inflation, 10, and then hyperinflation down around the 12th rib mark for those diaphragms. So that's a kind of a little bit of a gauge you can see. So those lungs are going to look really tall. You're going to have that tall lung look because those diaphragms are going to be flattened down. So before we even see this patient's x-ray, based on his clinical presentation and his baseline PFTs, we start thinking about his capacities, his volumes, those kind of things. We almost have an idea what we might see on a chest film for this patient. Okay? Give me just a second to get this pulled up here. Maybe I'll have a drink of coffee. It's being slow, and I'm sorry. This is not the time for this. I don't know what that is. It always makes that funny noise for me. Okay, I'm going to turn this around and show you guys this. Oops. Okay, here we go. All right, here's his chest film. So this is one of 4 that they did. Let me see if I can get you. That seems to be a little better. Let's see if we can make that so that it's... I didn't really mean to push that button. This is kind of what I wanted to do. Okay, so we have a little bit of rotation in this, but you can kind of see here that immediately you think, okay, this patient has pretty severe COPD, and we already knew that by looking over all of his lab values and stuff. What are you thinking we're seeing? Down here, really low flat diaphragms. A little bit of this right heart border is over there on that side of the mediastinum. His trachea is not straight or midline. I believe it's just a little bit of rotation. Here's his aortic arch. You can look and see down here. We definitely have some sort of an infiltrate in that. So how do we know if this is in the right middle lobe or if it's in the right lower lobe? Gosh, guys, I'm sorry, I keep moving the phone. So if the only way we'll know where this is actually is because this is an anterior to posterior film. So we're just looking straight from anterior to posterior. The patient is a lateral, and I do believe we have one in this group. So here's a lateral film. And so we're going to look and see. That heart looks pretty big out there. So the right middle lobe goes a little bit, anterior, posterior. We learned about this in pulmonary assessment, so I hope you guys remember. The right lower lobe goes posteriorly, and the right middle lobe goes anteriorly. So I might suspect and say that this is a right middle lobe thing based on that. This is a little alarming because this is air. It looks like he has a little bit of, you're wondering if he has like a pneumomediastinum or something like that. So luckily for this patient, I read ahead a little bit, and they did a CT scan because they wanted to see kind of where that infiltrate was and what it was. And let me see if I can go to the reports and read about that real quick. No imaging reports found. Okay, well, something's going a little absurd there. But let's go back into here and let's pull up a CT scan and we can look through that together as well. So pretty classic COPD chest film. Definitely some stuff here, low flat diaphragms, long tall lungs. You can see it's just kind of a lot of stuff going on here. Bear with me while I pull up this. Okay, I'm gonna put my phone right here. If I stop this, I don't know how to splice these all together for the video. You guys know I'm not very good at techie stuff, right? Okay. Please open for me. Sorry, I think it was telling me I had too many windows open. I know this downtime is a little bit boring. Okay, what do we got going here? Oh, there you are. Okay, let's get it over here and get it opened up. I'll make it big. Oh, there's it really good. Okay, so they did a lateral on that too, so you can see, look at that. So that, we don't know if that's like an infiltrate. We know he doesn't have an elevated white count, so we might almost think that that might be a little bit of atelectasis in that. We know it's on the right side. We saw that on the AP film, and on the lateral you can see that's pretty anterior, so we think that might be in that right middle lobe. Okay, so starting here, okay, so already we've got a big air pocket here. So this is the apices of the right lung. Look over here at this left side. Okay, oh my heavens. Okay, so these are big, I don't know if you guys can see this. This is unreal. Okay, I should have looked at this before, so we could have talked about this a little bit. So this is a big bullous emphysema. Okay, you can see that there's not a lot of vasculature around it. They're these gigantic big air pockets. So do you think having these big bullous emphysema areas of the lung is going to cause your patient to have an increase in dead space ventilation? And why? So those big old areas of the lung, so we're moving down here. So let's go up so we know kind of where we're at. Okay, we have big bulli up here in these apices, and that is actually so big that it's pushing over there. So we're headed down. Let's go all the way up here. So we're headed down. This is kind of crazy. I should have looked at this before so we could talk about it. Here's your aortic arch here. Here's your carina, and here's the bifurcation. So into your right side here, and you can start to see that into your left side here. Okay, so this is heading down into your left lung, and you can see all of these areas where there's this big dead space ventilation. There's that infiltrate that we saw. Okay, and then more of that bullous emphysema. So here's our big ol' diaphragm coming up, but look at these big spaces down here. So if you look at the chest film and you see something like this, you know that that's probably why this patient has that CO2 of 90 and a normal pH. His body spends an awful lot of time, so that's pretty anterior, that infiltrate there. So we got to worry about that a little bit, because that can cause some atelectasis. It's hard to say if it's just compressed lung. He doesn't have an elevated white count. Gosh, I hope that I'm holding this sort of still for you guys while I'm flipping through these. This is pretty impressive. This is a very interesting part of the slide way down in the lungs. So you can see that way down in those alveoli, all that trapped air. So this makes sense why his residual volume is so high. This is kind of down in his lung bases, and we have these huge big areas of bulli or just severe emphysema. So that is his CT scan. Okay. So you guys had some questions about your lab. So I think I'm going to try to put this down here and see how this works out. I think you guys will be able to see that pretty good on there. And I'll grab my trusty little marker. So this patient is a DNR/DNI. We know that, okay? We know he does not want to be resuscitated or intubated. So when he comes in, we don't have a lot of options if he starts having an increased work of breathing or if this pH starts to fall at all. So bilevel ventilation. This is what you guys are learning about. When to initiate it. Is it indicated in this patient? Choose your levels. Okay, so I don't know if that's going to work for you guys. I hope you can see. Maybe I should hold it up like this. So we talked about the IPAP and the EPAP. Okay, ventilation, oxygenation. So we kind of set this one down here for oxygenation, and then we increase this one for ventilation. Something we kind of have to think about in this patient is, do we add PEEP, or what kind of EPAP or CPAP do we want to set with this patient? Okay, we got to think about, this patient has a lot of air trapping, and if we add more positive pressure in the lungs, are we going to mess with his already compromised heart to decrease his preload and decrease his cardiac output by increasing his intrathoracic pressure if we put too much PEEP in there, or too much EPAP or CPAP? What should our delta P be? And that's our IPAP and EPAP, our difference between our inspiratory and expiratory pressures. So when to initiate. So if we have a patient that comes in like this, we don't want to blow off a whole bunch of CO2, because if we do that, we know he's going to dump his bicarb, and then he's going to get acidotic the second this starts coming back up, right? Because we know about how quickly all of these change this number. So we are okay with a pH like this. So are we going to initiate it just solely based on this ABG? Probably not. So it would be a work of breathing, or something that we're trying to do to help this patient overcome this, or if we're going to initiate like long-term nocturnal ventilation, bilevel ventilation, something to help him if he starts having hypercapnic respiratory failure all the time. If he went into kidney failure and wasn't able to retain this bicarb, or something happened where he wasn't able to produce and maintain this bicarb as a buffer, we would probably have to talk more about this. What is indicated in this patient? So choose levels. So would we want to add PEEP in this patient? So what we have to start thinking about when we're talking about ventilation and additional ventilation for this patient, or any COPD patient, with this kind of airflow, and especially this kind of airflow, so 13% in those little tiny airways. I don't know if you guys, if I'm doing this, doing you any service here. So what do we need to consider for this patient? We have to think a lot about this inspiratory to expiratory time, I to E time. So what should we have? Normal for us is like 1 to 3. These COPD patients with this terrible airflow, we need to think about extending that E time, okay? So do we add PEEP in this patient? So sometimes COPD patients can have what's called auto PEEP, or intrinsic PEEP, that can increase their work of breathing, okay? So essentially they're having to breathe through PEEP to initiate a breath. So if we're going to assist them with ventilation, it's okay to add a little bit of PEEP, because sometimes it helps them to overcome that intrinsic PEEP. So how do we know if we have air trapping, auto PEEP, or intrinsic PEEP? Your patient's going to have an increased work of breathing because they're going to have a harder time triggering that inspiratory breath through that auto PEEP. So there's a couple ways to check if you have auto PEEP or intrinsic PEEP with your patient. You can check your flow waveform. If your flow waveform, if it doesn't go back to baseline at end exhalation, you likely have some auto PEEP. You can check, you can do an expiratory hold if you're ventilating the patient, but that's not probably going to work real well with non-invasive ventilation. So a good way to just check is to see if that flow waveform gets back to baseline before the patient inhales again. So at end of exhalation, is there any flow? If there is flow, they're likely still trying to exhale when they need another breath. So what we have to think about is increasing the E time. This will probably be a whole nother case study. Okay, I just don't think that's gonna work. I think I better just hold it up here, even though I have a hard time writing, and all I do is talk. You guys already know that. Okay, so let's think about the I to E ratio. We want it to be 1, so 1 to 3 is normal, and we want about 1 to 5 for this patient based on this, okay? So some ways that we can increase their inspiratory time is these are some settings like on the B60 or things you could change, okay? This is not in spontaneous, but this would be in a rate mode. You could change the rate. So if you want a longer E time, what are you going to do to the rate? You're going to have to decrease the rate, okay? Because you're going to have to do fewer breaths per minute if you want a longer expiratory time. You can change the pressure support, which changes the tidal volume. And what are you going to have to do to the tidal volume if you want a longer E time? You're going to have to decrease it. Okay, decreasing the rate and decreasing the tidal volume can compromise your alveolar ventilation. So you got to kind of think about, is that something we want to do? Okay, the main thing, or the first thing you probably want to try to do if you're trying to extend their expiratory time, is to change your flow or increase your rise time. So that's going to decrease your inspiratory. So it's going to decrease this so that this can lengthen, okay? So if you do a faster rise time, you're going to get your breath faster, and that's going to decrease your inspiratory time and give you longer time for exhalation. So I hope that doesn't confuse you. Those are some things we have to think about on our patient if we're going to give him some assistance with ventilation, okay? Changing the rate changes the I to E because it gives you more time for each of them. Changing the tidal volume does the same thing, but you have to be aware that you can compromise your alveolar ventilation if you start messing with your rate and your tidal volume via your delta P, or change in pressure support, okay? So do we add PEEP? Yes, we add PEEP enough to overcome if they have auto PEEP or intrinsic PEEP, okay? So we do want an EPAP pressure on these patients. We don't want so much that we could cause barotrauma, or that we can start increasing that intrathoracic pressure to a point where we are decreasing our preload and our cardiac output through that, squishing that heart so that it isn't able to pump. So bilevel ventilation, is it indicated? So when to initiate it? When we don't like our ABG. Or, so we have an ugly ABG or a high work of breathing, okay? And an ugly ABG can mean anything from not being able to maintain our bicarb to not being able to maintain or to store bicarb fast enough to buffer out this CO2. So if this goes up real quick, we know this takes a few days to increase. Where this goes up, this can change real quick. This changes your pH really quick. So if we have an ugly ABG or an increased work of breathing, we can absolutely initiate bilevel ventilation for this patient. He is adamantly refusing, and we're not pushing the issue because of this normal pH, okay? If this was ugly, we would initiate it. We would not really care. Is it indicated in this patient? Well, it kind of depends on this, right? And what levels are we going to choose? So we're going to choose an EPAP level to help overcome that intrinsic PEEP or auto PEEP, and we're going to adjust our stuff so that we still get a longer expiratory time, because we know we need that for this patient. And so we're going to do our delta P. So are we going to say something, how much pressure support do we need? Well, if we're doing it for an ugly ABG, our pressure support depends solely on this and this, okay? So if that makes sense, if we have this ugly ABG, we're going to adjust our delta P based solely on this PaCO2 and pH. Okay, if we have an increased work of breathing, we're going to adjust our delta P just to overcome that increased work of breathing. Okay, so I hope that helps you guys a little bit. This patient was given 125 milligrams of Solu-Medrol, and then switched to 60, and then they tapered him down to his baseline of 20 a day. So we took care of this inflammation part of this. He was given Duoneb Q4, and and high flow humidified oxygen. And we were able to, they did a little bit of secretion clearance therapy to work with that infiltrate in that right middle lobe. And there isn't a lot we can do for this. He does have a positive bronchodilator response, so we want to look at his outpatient medication. Is his pharmacology covered for that? Do we need to send him home with an aerobica to keep those secretions clear out of there? And then is he covered here? So we need to make sure that when we discharge him, that he has whatever he needs for his bronchoconstriction portion of his COPD, something for his secretion clearance, and then make sure he's on his anti-inflammatories every day. So some things we can do there, because there's not much else we can do for this patient. Outpatient, so we do, so for outpatient with this kind of COPD, we think about quality of life. Because we have maximized his pharmacology, and we're working on everything we can for his COPD. We didn't really touch on this, but he adamantly refuses. I couldn't find a sleep study. If his AHI was high, I would have gone on that soapbox too, but I could not find a sleep study for him, so I'm not sure if that was done in the community. So quality of life, so we consider pulmonary rehab, COPD education, and oxygen titration for his outpatient regimen. So because we've maximized our pharmacology for this patient, what we can give him, and it looks like we're covering all of our bases, then we want to start thinking about his outpatient regimen, which is quality of life. Make sure he's compliant with his medications, and if he has a albuterol inhaler, make sure that he's taking it appropriately and with an aero chamber. And so it's education. So Q4 on those, and then 20 on this, and then he is on Spiriva. And so he is on a llama. So make sure he's taking this every day. This is Q4, over here. So the Spiriva, the albuterol, and the prednisone. And those are some things to consider. If you guys have any questions about this, please shoot me a text or an email. Hope you guys are having a great day.